The bypass run went long. There's fluid around the heart. The hole is still there. Something is up.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
Alice, will you remind our listeners what we do here at PedsCrit?
Absolutely. PedsCrit is an educational podcast. We are looking for our favorite attendings to give their bedside teaching spiels so we can really start a conversation about the management of critical illness across the country and the globe.
Sure, fantastic. And who do we have joining us today?
Today we have fan favorite at Children's National, Dr. Greg Yurasek. Dr. Yurasek is a graduate of the Columbia University College of Physicians and Surgeons. He did residency at Children's Hospital of Boston, followed by a full pediatric cardiology fellowship also at Boston Children's and his PICU fellowship at Mass General Hospital. He is now a CICU attending and the director of critical care simulation at Children's National. He was my attending last week, and I am so excited that we've landed him for the pod.
Today, we're doing a deep dive on all things ventricular septal defect. So we talk about the pre-op considerations that you need to keep in mind as an intensivist, what they're actually doing in the operating room, and then most importantly, what you need to look out for after they come back to the cardiac ICU.
I am embarrassed and proud to have learned so much from putting together this episode. So let's get right to the content.
That's right, let's go.
We are here today with Dr. Greg Yurasek. For those of you who weren't rounding with him last week, Dr. Yurasek is a cardiac intensivist at Children's National. Greg, thank you so much for joining us today.
It's a pleasure to be here. I've been working at Children's for about 7 years now, just in the CI, and I'm director of education there for the unit. And then my time that I spend when I'm not in the unit is in the simulation center where I run the critical care simulation for the hospital. It's great to be here today.
Thank you. Zach, you have to see the ECMO sim where a cardiac surgeon critiques your compressions. And I think that there are virtual reality sims too, but I haven't done
Yeah, they're coming to a classroom near you this fall.
How about we go ahead and jump in with our first episode today? So the first part of our conversation will be focusing on ventricular septal defect repair, or VSD. So Greg, thinking about a VSD, it seems like something that's pretty self-explanatory, but are there any relevant subtypes that we need to know about, and maybe any common coexisting lesions we need to keep in mind?
I'm glad you're bringing that up, Zach. There are a few different subtypes, and it's important to know them, but probably even more important to know which ones happen most often. And as a PICU fellow, what kind of patients you might be taking care of most commonly. Sort of the defect that you'll see most often is a muscular VSD, but it's actually one of the ones you might be recovering a child from least often. And that's because a lot of those close on their own. They can be associated with a variety of other genetic issues. And I don't think I was going to spend a lot of time with them, simply to say that there are holes in the muscular septum between the left and right ventricle. They could be big, they could be small, they're often multiple, and some of them can be closed with surgery and some of them can be closed in catheter-based operations. But because so many close on their own, they often don't require intervention. One of the more common ones that you might see is something called a membranous VSD. And like a lot of things in cardiology, especially pediatric cardiology, it's got about 6 different names to it: paramembranous, perimembranous, subaortic, and membranous. Those 4 things actually essentially mean the same thing. In your mind's eye, if you just picture the defect just underneath the aortic valve, specifically underneath the right cusp, that's sort of where that hole is. If you sort of imagine the ventricular septum as sort of a composite of an inlet part, which comes sort of posteriorly, starting from the AV valves, an outlet part, which is sort of where the vessels, the great vessels, are sharing the same tissue that's called the conal septum. And then sort of anterior part, which is the muscular septum. And if you were to imagine, like on a map, the intersection of those 3 places, that's the membranous VSD. And because a few interesting embryological things have to happen for that to form, that's believed to be why that's a common place where there can be a hole where tissues just don't meet appropriately. If it's big enough, and I think we'll get into, sort of restrictive versus unrestrictive and what sort of patients become symptomatic from having VSDs, then it would need to be closed, and it's something that you might see quite a bit as far as recovering a child from that kind of surgery. A third type, and this you'll see a lot, is an outlet type. So just like we talked about just a second ago, sort of the great vessels sharing that conal septal tissue. Well, what if there's defects in the conal septum? The most common outlet type VSD that you're going to see is associated with tetralogy of Fallot. It's a little difficult to do this with just audio, but the idea is that if there's tissue that's missing in the outflow septum, then the area sort of distal to that can be sprung sort of forward or backwards. And when it's sprung forward, because the pulmonary valve is anterior to the aortic valve, you get pulmonary stenosis, you get an aortic override, you get right ventricular hypertrophy, and of course you get this big VSD. And that's what we call tetralogy of Fallot, but it isn't really four things, it's just one thing, and it's the kind of VSD that we just described. The fourth type that you will definitely see are inlet VSDs. Some folks like to call these canal-type VSDs. Some cardiologists really get upset about that terminology because it's not a canal-type VSD unless it's a canal. I'll just say I think it's fine no matter what you want to call it as long as you're consistent. So inlet just basically means, the AV valves are really posterior in the heart. And this is the part of the septum that's posterior in the heart. It's right underneath those valves. So you can imagine if you don't form two AV valves, let's say you have a common AV valve like a canal, there's probably going to be some, ventricular septal tissue missing. And so that's the kind of VSD that we see. These are often big, and they're often associated with primum ASDs, which is sort of the most inferior aspect of the atrial septum, which we're not going to talk about right now. And when you see issues with AV valves, primum ASDs, and inlet VSDs, you're starting to talk about canals. But the idea of the VSD for that is, again, it's inlet, it's posterior, it's usually big, and these do not close on their own. And the fourth kind is this kind that people have debated about for a long time called a supercritical VSD. All I'll say is it's underneath the pulmonary valve. They're often sizable, but they're really easy to close, and they're very, very rare. So just to review, the kinds that you're going to see the most are probably going to be canal type or inlet VSDs, outlet type or conoventricular VSDs, and sort of right in the middle of the heart type or membranous VSDs.
Seems there's certainly a lot to know about the different types, but you mentioned earlier restrictive versus unrestrictive. What exactly does that mean, and how is that relevant for our patients?
That's a great question, Zach. Alice and I have talked a lot about how cardiologists like to use fancy terms to describe simple things, and pediatric intensivists don't. They speak plain English. And having done both fellowships, I feel I'm in a reasonable position to make that statement. From a cardiology standpoint, all that restrictive means is that there's a pressure difference or a gradient in between the two chambers. So if it's a VSD, right, we're talking about something between the left ventricle and the right ventricle. That's clear. If it's restrictive, that means there's going to be a pressure difference or some sort of a delta between the left and right ventricle. And as long as it's a patient with sort of normally aligned ventricular substrate, that's going to mean that the flow is going to be from the left ventricle into the right ventricle. If it's restrictive and there's a pressure difference, it just sort of makes common sense that it's probably smaller because not all of the flow is getting across the defect in each systolic cardiac cycle. If it's unrestrictive, it's going to be big, which is to say that at the end of systole, the right and left ventricular pressures will essentially be the same. Big defects tend to put kids in heart failure pretty quickly and universally need to be fixed. Small defects we sometimes can sit on depending on where they're located.
And this is also the language when we talk about single ventricle patients or patients who require atrial mixing. The atrial septum is restrictive or it's unrestrictive, right? Like it's just the same.
That's right. That's exactly the same thing. You're totally right, Allison. The thing to keep in mind is that the ventricles are squeezing chambers. I mean, they have to fill, but the work that they do is they push stuff out. And so when we talk about restrictive or unrestrictive, we're talking about systolic phenomenon, squeezing phenomenon. At the atrial level, remember that the left atrium is just an extension of the pulmonary veins. The right atrium is just an extension, right, of the cava. And so all they're trying to do is align that blood that's coming back into the heart in a better way with a valve to then passively flow it into the respective ventricles. Because they're passively flowing blood into the respective ventricles, there's, of course, atrial systole, but most of that flow is actually passive. That's a diastolic phenomenon. So when we think of is that a restrictive ASD, think about, do the pressures in the chambers, the atrial chambers, equalize in diastole? If you're thinking about a unrestricted or restrictive VSD, you're asking yourself, do the pressures equalize in systole?
Nice. Okay. So we've got these two sort of rough buckets to put our VSDs in. When are these kids, depending on how depending on the pressure differential, when are these kids typically taken to the OR? When are they getting repaired?
That's a great question. So probably best to start from sort of the ideal patient and then kind of work our way backwards. So if you have a term child, they're not born early, their entrance into the world was uneventful, the diagnosis maybe was made at a 20 or 22-week surveillance, or maybe it was made by a murmur soon after the child was born. And let's say it's a big defect. So the child gets an echocardiogram and say, wow, it's a big defect, 5, 6, 7 millimeter VSD, which would be pretty sizable. Those kids generally do very, very well for the first 4 to 6, even 8 weeks, requiring very little. And they begin to develop heart failure, which we'll get into in a second, and get repaired anywhere from 2 months to 4 months, and even up to 6 months. These babies are often fine. The sorts of symptoms that we'll see are completely and entirely related to the natural dropping of the pulmonary vascular resistance. And so when you think about a VSD and you think, okay, well, how do I figure out how much flow is going to go from the left ventricle to the right ventricle instead of from the left ventricle to the aorta where it should go? That difference is going to be driven by how high the pulmonary vascular resistance is. When babies are first born, all babies, term babies and premature babies, the pulmonary vascular resistance is equivalent to or even slightly above the systemic vascular resistance. What that basically means is that there's going to be no net left to right or left ventricle to right ventricular flow. And the child might be a little blue because there'll be bidirectional flow across the VSD, which can lead to some cyanosis, but they won't have a lot of extra pulmonary blood flow and they won't develop heart failure. And we probably should just take a quick second and just define heart failure. It's another one of those terms that cardiologists love to use in pediatrics and then not at all define it. So if you're working with a 70-year-old man, heart failure is systolic heart failure. The pump isn't working, and it's usually because of coronary vascular disease, right? And that's like heart failure for like 98% of the world's heart failure population. For this other very small amount that we're dealing with, which is pediatric heart failure or heart failure related to shunt lesions typically, the pump is fine. And that's good to keep in mind, especially when you're talking with families. You hear the word heart failure and you're the parent of a 2-month-old, you think this does not sound good. If you then qualify your statement and say the failure is just that too much blood is going to the lungs, giving the child sort of an imperfect respiratory profile, a little extra fluid on the lungs, breathing a little quickly. Remember, babies pretty much just have to breathe or swallow. And if you're breathing too fast, you can't swallow. And if you can't swallow, you can't gain weight. And so that's why typically these babies are just fine from a squeezing standpoint, but they tend to breathe quickly and eventually fall off their growth curve. And that's when we typically intervene.
I think that's really helpful, that mental framework of defining exactly what pediatric heart failure is in these neonates and keeping in mind that concept of pulmonary vascular resistance dropping those first few weeks, because it's so relevant to almost all of the neonates that we take care of in the cardiac ICU who have some type of congenital lesion. Coming back to our topic here, when you have that patient with a VSD, it's decided this patient needs to be repaired. What are the options for these children? Do they all go to the OR, or is there a catheter-based approach? And if it is just OR, what do they generally do for these?
Typically, if we kind of bring our attention to those, like I'd say, 3 most common type of VSDs, the posterior ones or inlet ones, which tend to be pretty big and they're close to the AV valves, and then the membranous one, which is sort of like in the middle of the heart, and then the outlet ones, which happen to be, typically related to the great vessels. If you were to just imagine how you would in your mind's eye want to fix those, it's good to think about how that could be done, because then it makes sense sort of how the surgery goes. So first of all, is it possible to put a device in these? Well, of course, the question's been asked, but if you think of those 3 kinds, you'll see that that's probably not going to be possible except a very, very kind of rare, almost like palliative type conditions. In the inflow side, if you put a device in there, you're going to be messing with the inflow of the entire, both sides of the heart. And also the AV node lives back there. So lots of things will not go well if you attempt to close an inflow or canal type VSD with a device. A membranous device, similarly, it's difficult to see devices in there. You can land patients with a lot of aortic obstruction if you try to do that. Just because of where the device is, you can get something called subaortic stenosis and also heart block because the node is close to that too. And last, conoventriculars are just too big and they're not shaped like a circle or anything that you could actually imagine to put across them and stop the flow. It's the muscular ones, which, again, we won't spend too much time with, but because those are far away from like real clutch structures, and also because they're far away from the surgeon's eye, those, especially the apical ones down by the apex of the heart, those can be closed by devices. But for our purposes, Zach, we'd be talking about operations, and that's just because the catheter-based approaches would be potentially harmful and rarely successful. Maybe moving on to how to actually fix them.
Yeah, how did they get that?
So understanding the anatomy, of course, is the first ticket to understanding how they're fixed. They all involve a different kind of fixing involving closing a hole. And the easiest one to think of conceptually is the membranous, because that is typically not associated with great vessel problems, AV valve problems. It truly is just a hole in the heart. And so the surgeons usually, when they put the child on bypass and they resect a lot of the pericardium, they put it in the stuff called glutaraldehyde, which sort of preps the tissue, makes it a little firm. Happens in just a few minutes. And then they can harness that and just repair the defect with that. For ASDs, that's used universally. For VSDs, depending on how big they are, often a Dacron patch or something that is foreign material is used. These don't grow with the patient, but because the tissue around them grows with the patient, the hole doesn't reform. But it's important to consider that if you use a Dacron patch or any kind of foreign material, the child will have that foreign material in forever, of course. Outlet VSDs involve a little more creativity, and that's just simply because they're bigger, they have an odd shape, they're often associated with other problems. The tetralogy one, for example, right? Because you can't just close the hole. You have to do it in a way where the pulmonary stenosis is relieved. And so that can involve cutting into the pulmonary valve, resecting the tissue, dilating the valve. There's a bunch of different approaches depending on what kind of a tetralogy the patient is. But end of the day, it does involve closing a sizable outlet VSD, and that would always be with patch material because the vessels are, of course, under systolic pressure, and a autologous pericardium would not be strong enough to hold that. And then last, with the inflow VSDs, those are tricky, and that's because they involve AV valve work. So typically a patch is used to sort of bridge the gap between the AV valves and then the crest of the ventricular septum beneath them. Sometimes that patch is sewn right into it, and that's called an Australian repair. Sometimes it's sewn not into it, but sort of into the patch itself, which is just a classic two-patch repair. And then the second part of the operation is closing the ASD, and usually a cleft in the AV valves, typically on the left side. So those are kind of the three surgical approaches to the three most common VSDs, but they all involve open heart surgery.
Nice. And now, correct me if I'm wrong, but until I was really reading about these procedures, I had not realized that they were doing all this work looking through the tricuspid valve at the ventricle. It gives me so much more respect for what they're doing, is that they're literally like getting in there in the valve to close.
That's a great point. I was well into my fellowship before I realized that. And honestly, the only thing that clued me into that is when you're, at least where I trained as a second year fellow, maybe a late first year fellow, you start doing all of the postoperative transesophageal echoes. And so you go on down there and you get this bird's eye view of what's going on. And it's sort of, that's your introduction to real congenital heart surgery. You do the pre, and then they do the operation and they call you down and you do the post. And you're like, wow, this is really different. And I was here like an hour ago. And it's fascinating. And you're right, Alice, for the membranous VSDs, typically that can be closed right through the tricuspid valve. So the approach essentially is through an atriotomy, which is in part of how you get the patient on bypass to begin with. The septal leaflet, the medial most leaflet of the tricuspid valve is usually moved a little anterior and right through the chordae, which connect to the papillary muscle. The defect can be closed pretty readily and seen pretty readily, of course, with great surgical experience and technique. The outlet ones can't really be done that way. And if you have there's so many cool tools online, or you can come to our VR lab and see some too if you want. But the pulmonary valve is very, very anterior. So there's really no way that if you looked through the tricuspid valve, you're able to see the outlet. It's all the way anterior and it's heading off to the patient's left. Remember your anatomy, like that goes to the patient's left and the aortic valve goes to the patient's right. There's just no way you can actually see it. There's sort of three parts of the right ventricle, sort of an inflow, a filling, and then this outflow chamber, which you might recall is called the infundibulum, and it's just not in the surgeon's line of vision. So that's why for a tetralogy type repair, the surgeons actually have to cut into the valve and take that incision down to something you may remember from anatomy class called the moderator band. Dun, dun, dun. And that opens up the right ventricle quite a bit, and that's how they can see the outflow.
Interesting.
And finally, when it comes to canal type or inlet type VSDs, they can be closed largely through the right atrium, but it's a bigger incision and it's a longer process to do it, and they have to be able to look through both of the AV valves, but with skill, they can also be closed essentially through atrial tissue.
Nice.
That's so neat how they're able to go through the valve to do the majority of these repairs.
Yeah.
Imagining that we're in the CVICU, we're waiting on this kid to get back, the surgical team, the anesthesia team roll back with the patient. What do you want to hear from them to ensure good quality handover? What information from the case do you want to know and why?
That's such a great question. And most of the time that I spend with the fellows, I'm trying to think about the process of signing out and how we can communicate, just like you suggested, the right information without too much information. So there's the sort of two parts. The first part is the information that needs to be conveyed. And then maybe we'll jump to like specifically for a VSD, what makes you a little concerned versus this was a VSD repair, this kid's fine. So the first part, and a lot of institutions, the three places I've worked at, all sort of do it the same way. It doesn't need to be done this way as long as the information is conveyed appropriately. Usually the surgeon or the surgical fellow, we love to get the attending there, but sometimes they're busy talking to the family after the operation. So the surgical fellow will describe the patient's basic history, the procedure that was going to be done, and then what was actually done. And then the anesthesiologist, and typically the attendings are there, although the fellows may provide the numbers, will really go through a nice detail. They'll go into the history a little bit more. For example, does this patient have trisomy 21? Do they have anything that we should know about that? Do they have obstructive sleep apnea? Is there any other interesting things about them? Is there concern for pulmonary hypertension? Just so that you have a frame of the patient then to put the VSD in there. It's not just a VSD, right? It's a VSD in a patient with X, Y, and Z. They'll go through the actual anesthetic course. Did they premedicate? What did they use? They'll tell you what kind of a child it is. It's really important. We never talk about that, right? Sometimes, when you wake up a 6-month-old after a surgery, some of these babies are pretty chill and some of them are not. It's really good to know what they were like in the pre-op area. I find myself listening more and more to that part of the sign-out as the years have gone by. They'll talk about where they got access, first putting in peripheral IVs, how they secured the airway, were there any issues with that? We usually do nasotracheal intubation for our babies. They'll talk about what central lines are involved, and that usually is a neck line, an IJ line, and some sort of a peripheral arterial line. If the surgeons know they're going to put intercardiac lines in, then the anesthesiologist usually won't go through the trouble of putting a line in the IJ because we'll have plenty of access. A Foley, of course, is inserted as part of this, and then the surgeons come open, do the procedure. We get the imaging before and after. The imaging at the end sort of concludes the procedure. The chest is closed the majority of the time, but certainly for a VSD, it would essentially always be closed. And the child is either extubated in the OR or brought up to us intubated. And so that information needs to be conveyed. And at least the places I've worked, Zach, about 75% of that information is from the anesthesiologist. Really important detailed history so that you know how did it, like when the child needed to be intubated, was the child stable, or did they intubate the child in 20 seconds and the saturation was 40%? Just to let you know that maybe if this child gets in trouble when you extubate them, you may not have a lot of reserve. Gives you a lot of good information. And then, of course, from the surgical standpoint, looking at the repair itself, how did the post-op study look? And are there any other complications? And, of course, the surgeons may say, this baby's coming to you now, but we were in the operating room for 6 hours with this baby and 2 or 3 bypass runs. I think it'd be great to just keep this child stable tonight and not extubate. They will often make their opinions heard and felt, which is certainly very reasonable. You always want to take that into consideration as an intensivist. And then the second part of this is, what are the red flags? What would you worry about? And this again goes right back to anatomy. So if they were to say, I'll just give a couple examples. If the patient needed to be paced coming off and they're still being paced, and you look at the pacing spikes on the monitor and you can see that they're being sequentially paced, that is, their atria and their ventricles are being paced, you might think, is this patient being paced for heart block? And is this a complication of this surgery? That'd be a thing that I would look at the monitor immediately. A second thing is, remember when you're closing a VSD, no matter what the VSD is, it's communication between the left and the right ventricle. As a result, if you close the hole, the left ventricle should have better stroke volume, better systemic output, fancy way, more flow across the aortic valve every beat. As a result, these patients should be a little hypertensive, often a lot hypertensive. If you have a membranous VSD or a canal or anything, any baby that comes back from the OR and the blood pressure is 60/30 and they're on a bunch of norepinephrine, even if the lactate's low and the kid looks okay, be wary. That is concerning. Something is not totally right about that. The bypass run went really long. There's fluid around the heart. The hole is still there. Something is up. And so that's an important thing. So you'd want to see the patient's rhythm to be okay, specifically the atrioventricular concordance, or, synchrony, I should say. And so if they're paced, are they just paced for slow sinus because they were a little cold? That's fine. But if they're being paced at the ventricular level for block, you want to know about that, and you want to raise a kind of a level of concern for the people that you're working with that evening. Hypertension would be expected. Normal tension's fine. Hypotension after a VSD repair is not common. And then, of course, bleeding. What kind of blood products? Was this, gave the child a unit on pump, some cryo and some platelets, and I'm leaving you 60 cc's of blood in case you need, and then the first hematocrit is 35. That's what I would like to see. Right? If the child comes up and there's a lot of blood products in the medical record that you see having been given, and they didn't bring any blood up because they used it all down there, that's a concerning thing, and you want to be worrisome. And as you're signing out, this process takes a good 15 minutes. Just look at the chest tubes. Are they just sort of putting out gently? Is it really red, or is it already starting to dilute? There's a lot of information you could learn in those first few minutes when they come back.
Yeah, absolutely. When we think about typical post-op course, would you say expect them to come up a little hypertensive, maybe requiring some NiCard, 6 to 8 hours after bypass, expect a slump where you'll need to be taking them off of the NiCard and plus minus a little bit of pressors, and then following morning, they should be back to hemodynamically stable?
That's a perfectly good approach, Alice. I think for cases that involve, and I'm going to give you some, this is more my experience and, subjective stuff. I don't think you'd see this in a chapter in a textbook. And I would say if a child is on bypass for, say, 90 minutes or less, and the cross clamp time, which is, the time that the heart is stopped, is, say, less than 45 minutes, and that would be typical for a membranous VSD, there actually shouldn't be too much of a slump.
Okay.
These babies, they'll come up a little hypertensive. You usually can extubate them in 2 hours. As soon as the bleeding's under control and there's no heart block, those are the only two criteria for that lesion that I would say I would definitely keep the kid intubated if those two things are happening. If those two things aren't happening, even if, maybe the kid's on a little bit of epi and maybe we've transfused once, just get the tube out. It's the best way to kind of move the child forward. And usually you don't have much of a slump to deal with. For tetralogy, again, that would be that outlet type VSD. This can take a little bit longer, and that's just because the procedure takes a little while. You're looking at usually 2 hours on pump and an hour of cross clamp, but sometimes more than that. Your risk for heart blocks much higher. More blood products typically are involved. And for, I know we're not going to go into the nuts and bolts of a tetralogy repair, but remember, you kind of have to address the VSD and the pulmonary valve. There's a number of parts. There's just more suture lines. There's more bleeding. And there's much higher risk for different kinds of arrhythmias, like junctional ectopic tachycardia, which will go away. And that is a bear to deal with if the child is extubated, and really quite easy if they're intubated. So those kids, we wait a little bit. And then last, for canals or the inlet type VSDs, about half of the canals that you'll see, up to 60%, have trisomy 21. And so a lot of those kids have at least some substrate for pulmonary hypertension. If not, they have pulmonary hypertension. A lot of those babies, we'll keep them quiet. And by quiet, I mean intubated and sedated for, 12 or 18 hours overnight, and sort of lift everything in the morning. And that's not universal. Some people feel very comfortable extubating a fresh canal immediately, and I don't think that's wrong. But for the reasons that I mentioned, I usually would wait. So again, membranous, probably extubate right away. Tetralogy would be sort of my next. As usually the slump isn't that much. It's just it's the arrhythmias that can be a bit of a problem. And the canals, I almost always wait till the next day.
I think it's really helpful hearing your mental model. Thinking about an isolated VSD patient, are there any other goals that you might have for that first postoperative night, maybe titrating diuretics or milrinone, and anything that's in general you would typically do?
It's a great question. There are many different ways to do this, and that's why I think when it comes to reading like the chapter on VSD repair, if you look at Moss and Adams or you If you read the East Coast text, as we say, versus the West Coast text, they're really different. And they're all based not really on evidence-based medicine, but on just professional practice and gold standards, which are great. You need those. But there's never going to be a trial that says, our VSDs get Milronone overnight versus yours that don't, and ours just do better. That's never going to happen. And that's just because the subtleties of how these medicines work are really hard to kind of predict, and also say that that particular patient needs that drug versus that patient doesn't. Then you throw in the mix that the people taking care of the kids during the day are often different than the ones at night. So there's no way to really have the exact same practice. And before you know it, you have sort of a free-for-all when it comes to taking care of these kids. End of the day, Zach, it's the goal for an uneventful VSD, let's say a membranous VSD, which is, I think, always a good place to start. If I were the surgeon and I were coming in that next morning, assuming that my work was good, I would want to make sure the child's extubated on maybe a little bit of oxygen and off any kind of medicine that would keep them in the ICU. Whether that's Milronone, and people, feel the Milronone will help attenuate low cardiac output syndrome, and that would be topic of a different discussion. That might be true and it might not be true, but either way, having it on for, past 4 or 5 in the morning after an uncomplicated VSD repair is probably not necessary. Things like Precedex for sedation, those are the sorts of things that leave you in the ICU for a couple of days. And so the idea as an intensive care doc, whether you're working in a mixed unit, in a CI, it doesn't matter, is for an uncomplicated VSD, you'd like to have that patient on a little bit of oxygen to keep the PVR down postoperatively, a little bit of diuretic to help keep the lungs as dry as you can as they're still recovering from bypass, and not on any drips that are keeping the child in the ICU. And if it's really any baby, you'd like to have maybe had them try to be fed at this point at least once.
Excellent.
So it seems like, in general, you want to try to get these patients out of the ICU the next day. Is that fair?
Yeah. Where I worked formally, we extubated the tetralogy patients faster and often moved them out the next day. And that would be more for your 60 or 90-day-old techs, like term, went home, not a particularly blue tet, came back at 3 months, got their repair. Those kids often can de-intensify quite a bit overnight. If you're doing a tetralogy and a patient who was spelling at 10 days of age, that's a very different operation, and they tend to be there for quite a bit longer. And then canals, I would say the average stay in our unit, actually I do know the average stay in our unit, and it's 2 days. The median is 2 days, not 1, and our TETS is 2 days, not 1. So we typically do get them extubated the next day and then de-intensified into day 2. Whereas a straight-up membranous VSD, all that typically happens the first night.
Nice. If we're talking to the families and they're asking about when do you think we'll finally be home after all of this, can we speak to that?
Absolutely. That's a great question. And this is where it's really helpful, if I might add, to have done a cardiology fellowship before doing this, because I feel for you guys a little bit, because the folks who have done the PICU training and then a year of cardiac ICU are amazing. And I work alongside them every day, and I'm honored to call them my colleagues. And we treat kids the same way, and I think we're as good as each other at the things that we do. There's a benefit, though, to having done outpatient cardiology, because you actually know how long it takes these kids to get home. And I always kind of feel for our friends in the PICU, because the families are asking you that too. And you're like, well, I can tell you when I think they're going to be extubated, right? And it's different. So usually what happens for let's say a 3-month-old with a VSD who just developed the signs of heart failure, as we described below, maybe they fell off their growth curve, but they've been eating at home, maybe on some diuretics, haven't been in and out of the hospital. This was an elective repair. That child's usually extubated the next day. They're usually on the floor, on the medical floor of the step-down unit. Depending if in some places that have mixed just keep the cardiac patients until they go home and just sort of change their billing. Some places, like our place, we actually obviously move them to a step down to make room for the next postoperative patient. So in the step down area, usually there's a day of sort of pain control. That's the thing that, you really have to work on that second day. The child's much more awake. They're trying to eat. They're trying to be held. We're trying to get lines out of them. It's actually a pretty challenging day. I think for nursing, the second day is often harder than the first. And for the families, it can be too, because now they're like, oh my goodness, their child really looks like they're uncomfortable and in a lot of pain. Whereas the first night, they just kind of are sedated and the operation's over, so you feel good. Mm-hmm. The second day can be really tough on our families. Typically for a VSD, you're home in about 4 days, 4 or 5 days. For a TET, it might be a couple days more. And for a canal as well. But if we're talking about an elective repair for those pretty, those 3 most common, I would say, VSD or VSD-based lesions that we keep coming back to, all those kids should be home in a week from the day of their operation, sometimes quite a bit less than that.
Oh, fantastic.
Yeah, I think it is helpful, especially, I don't have any kind of context for what happens outside the ICU for these kids.
Mm-hmm.
Of course.
When these kids do go home, say they have a membranous VSD, but maybe they get hospitalized for some other reason, maybe months, years down the road, what do we need to keep in mind that could be a possible long-term complication from their VSD repair?
That is a great question. And the long and short of that, Zach, is that we really don't know. There really aren't any studies out there that have sort of shed light on what we should worry about. There have been a lot of people who feel quite strongly to avoid elective operations kind of coming into respiratory viral season. Of course, with COVID, that has changed completely, and now we're getting viruses, as you will know, in the middle of July, which we never used to. And so I think that theory may be derailed just because of that a little bit. What we do know is this: kids who have open heart surgery are at higher risk for doing just generally worse, either needing hospitalization or needing ICU level care than patients who haven't. So if you and this makes just good sense, right? Let's say you have a bad broncholytic who's 7 months old, and you take one who had a VSD repair when they were 4 months old and one who didn't. The one who did is typically going to be in an ICU more likely and all the rest. The tough thing with trying to figure out why, Zach, is we're all human beings. And so the problem is the ER doc is going to say to the one who had open heart surgery, this kid's going to the unit. This is a heart baby, right? Mm-hmm. And so right away, your sort of positive predictive value of, if you will, of needing higher level of care and ending up on high flow or even intubated is higher, probably even if the babies looked exactly the same. The biggest risk to me and in my practice is that it typically takes kids several weeks to sort of get into a good nutritive state after an open heart surgery. So remember, these babies are going to go home in a week, right? But think of how many calories are now required for wound healing, how many calories are required for that little bit of pulmonary edema that's still there that raises the respiratory rate from, say, 30 to 50 minute after minute after minute. There's just a lot less caloric substrate to go around for just good weight gain and linear growth. And so that's one of the things that has led to people, and I believe this, babies not being quite as robust, if you will. But it's hard to define it. It's hard to say, well, it's because they're tachypnic. They're usually not tachypnic at home. It's because they still have pulmonary edema. That's usually gone in a week or so. It has to probably do with something related to lack of reserve that we haven't fully figured out. Now, of course, on another note, if you're talking about a baby with residual disease, that's a whole different story. And that makes good sense, right? What doesn't make as much sense is, yeah, but if the heart's fixed, the heart's fixed, right? The child should do the same. But they kind of are not so good that first wintry season typically. The kids with, for example, let's say a tetralogy repair, and they're left with really high right ventricular pressure, and their RV is working all the time. And maybe they have some tricuspid insufficiency, and that causes them to have a higher central venous pressure, and they've had some issues feeding from that. That baby is going to not do great the first time they get high fever, the first time they get dehydrated, the first time they get RSV. Similarly, let's take a canal, which, almost always you have to do a little bit of work on the left-sided AV valve, right? So that's sort of the physiology. We call it left-sided AV valve regurg, but effectively it's mitral regurg. If the operation leaves a child with a lot of left-sided AV valve regurg, LA pressure is higher. The pulmonary venous pressure is higher. The lungs are more vulnerable. Those lungs are not going to do great with fluid overload, fever, viral infection, things like that. So I think to answer your question, we don't totally know why babies need to be watched a little more closely if they have no residual disease, but it does stand to follow pretty nicely that the ones that do have residual disease, the primary care doctors need to know what that residual disease is and immediately make sure that the family is seeing medical attention, seeing their cardiologist anytime that child before the age of, say, 2 or 3 years old is coming down with something.
Well, that's very fair. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedcritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.